Hello, my name is Sicco and I'm the chair of the 2023 IWGDF working group on ulcer prevention that was tasked with updating the guidelines on the prevention of foot ulcers in persons with diabetes. The 2023 team consisted of people from different specialties ranging from podiatry to podiatric surgery, physical therapy and human movement science, and represented many different geographical regions in the world. This 2023 guideline on ulcer prevention updates the 2019 guideline, which was the previous one. And the target population in these guidelines has always been the at-risk person with diabetes with at least loss of pedestrian sensation or peripheral artery disease present. We identified 14 clinical questions or PICOs that were reviewed and commented on by an expert panel of people within the different regions in the world. And we also identified 13 critically important and important outcomes that were also reviewed by these same external experts. The systematic review that underlies the international guidelines identified 172 eligible studies, 10 meta-analyses were conducted and eventually resulted in 33 evidence statements. The guidelines contained 17 recommendations and 9 summary of judgments based on the evidence that was available. When it comes to ulcer prevention, we identify 5 key elements. The first one is identifying the at-risk foot, and we have one recommendation in the 2023 guideline on that. Secondly, it's regularly inspecting and examining the at-risk foot. Also one recommendation on that. The third key element is educating the patient, family and healthcare providers, and we have 5 recommendations on this topic. A fourth element is ensuring routine wearing of appropriate footwear, and we have 3 recommendations on that. And the fifth and final key element of prevention is treating risk factors for ulceration. So for example, treating callus that is present on the foot, or also surgical interventions for prevention. And we have 6 recommendations on that. Most often in foot care, these different elements are integrated, and the foot care consists of 2 or more of these elements, and we also have 1 recommendation on this integrated foot care. So what's new in the 2023 guideline? We used a more thorough grade methodological approach to the guideline. We performed meta-analyses where possible, which we didn't do in the previous ulcer prevention guideline. We added new clinical question on psychological intervention for ulcer prevention. We added new important outcomes, including health-related quality of life, costs, mortality, self-efficacy, well-being and adverse events. We split the recommendation on the use of footwear according to the severity of foot deformity present, and we reorganized the recommendations on treating non-rigid hammer toe to contain both a surgical and an orthotic intervention recommendation based on recent evidence that appeared from randomized controlled trial. So here I will not present all 17 recommendations of the ulcer prevention guideline, but I will highlight some of the recommendations where changes have appeared or where new recommendations have appeared. One is on ensuring routine wearing of appropriate footwear, where in a person with diabetes who is at risk of foot ulceration and who has no or limited foot deformity, no pre-ulcerative lesion and no plantar ulcer history present, so within the IWGDF risk category 1 to 3, the recommendation is to educate to wear footwear that accommodates the shape of the feet and that fits properly. This is a strong recommendation, however, based on low level of evidence. In a person with diabetes who is at risk of foot ulceration and who has a foot deformity that significantly increases pressure, or where a pre-ulcerative lesion is present in IWGDF risk category 2 or 3, the recommendation is to consider prescribing extra depth shoes, custom-made footwear, custom-made insoles, and or toe orthoses. This is a conditional recommendation with based on low level of evidence. So another aspect of treating risk factors of foot ulceration is surgical intervention, and the changed recommendation here is that in a person with diabetes who is at risk of foot ulceration, IWGDF risk categories 1 to 3, and a non-rigid hammer toe with nil changes, excess callus, or a pre-ulcerative lesion on the apex or distal part of the toe is present, the recommendation is to consider digital flexor tendon tenotomy for treating these outcomes and to help prevent a first or recurrent foot ulcer. This is a conditional recommendation, so we recommend to consider this approach, but it is based on moderate quality of evidence. And this is based on a randomized controlled trial that came out recently from Andersen et al. In Denmark, who assessed the efficacy of flexor tendon tenotomy treatment in 79 patients with impending ulcers and found a significantly reduced risk of ulcer recurrence in the group who had tendon tenotomy compared to the group who had non-surgical treatment. And also the number of ulcer-free days was higher in the tenotomy group. So here you see an effect where a randomized controlled trial on a particular topic has influence on the recommendations that we provide. The key considerations within the ulcer prevention guideline are that robust data are lacking on whom, how, and when to screen for ulcer risk. So the evidence-based base for this aspect of screening still needs to increase to provide more quality of evidence to support the recommendations made. High quality data on interventions to prevent a first foot ulcer are scarce, so most of the recommendations are related to prevention of ulcer recurrence, and we need more high quality data on first foot ulcer prevention. Costs and cost effectiveness analyses of interventions need more research and are not very present in the current systematic review and evidence-based. So original cost effectiveness studies are rare. And finally, adherence to an intervention is crucial in outcomes. This has already been presented in previous rounds of the guideline and has been confirmed in this guideline. So with increased adherence, better outcomes can be expected. The future research agenda that is part of the ulcer prevention guideline contains several research questions for future research, also based on these topics of key considerations. And we hope that clinical research teams will pick up these future research questions and the effort to study, so to increase the evidence base and make the recommendations on ulcer prevention stronger and further supportive. So this finishes the presentation of the ulcer prevention guidelines of the International Working Group on a Diabetic Foot.